being an orthopedic practice, it's a hospital system.
Yeah.
That, again, they were with one of the big carriers. They were already self-funded, but continuing to see their costs increase. The new CEO, she knew you from a previous life and what you were doing at her former hospital. So, I think what was different in this situation, she remembered you from that situation, and now we're years ahead, and you're much smarter now and looking at other options and kind of embracing some of these, community-owned health plan, mindsets and, health Rosetta principles. But yeah, this was kind of another fun one to bring this into fruition, if you want to kind of speak to that a little bit more.
Yeah. You learn so much every day in this business. It scares you. And just working on their finances, not being afraid of the math and asking some of the tough questions. And, how does your charge master work? And how is your relationship with the PPOs? Because by moving from one encapsulated carrier administrator mentality, it's like, well, I can't unplug this part and plug it in. So we, again, wanted to have access to providers was number one.
Where with this one, again, they were working with a big carrier, and of course they wanted to capitalize on their employees and their families using this hospital as much as possible. And I think they were just writing off some of the claims. So again, left pocket, right pocket. This carrier didn't allow them to set their own fee schedule. The carrier was taking their, piece of the pie along the way. They had their own internal pharmacy. However, they were working with one of the big three PBMs. So just trying to talk them through, as we say in this business, crawl, walk, run. Do you want to rip off the Band-Aid and, go all in on some of these strategies, or just start to chip away at maybe the pharmacy first, and then maybe the TPA, looking at outside stop loss, so on and so forth. The fun part for us was that, she was ready to rip off the Band-Aid and go all in. So
John, I want to run. That's what she said.
Yep,
said,
independent TPA. Yep. We worked with a regional network, wrapped it with a PPO network. So to your point, making sure employees have access not only to internal services at their organization, but externally with other providers. And then having a PBM at the table that was willing to work in tandem with their internal pharmacy. So that's all proven to, work.
Yeah, well, and I think the other thing too is as we've gone down the road, they've been able to see the numbers and kind of analyze what's going on. And so now we're taking a sprint. We're going to add sprint to the crawl, walk, run, sprint. And so now they want to sprint to, let's take our domestic claims out of the stop loss, because that's a question I had, because I am going to market. And when the red flag is when stop loss carrier says, can we have a report showing you the amount of claims that are going to the hospital? Because their fear at the stop loss carrier is, well, are they there to make money on their own health plan? And I just hate that question. And so we're like, well, guess what we're going to do is we're going to show you an option with your employees under stop loss at your group, your domestic claims. And we're going to show you an option where we're going to carve the stop loss out for the claims that happened in the hospital, because it's a critical access hospital. So they're not doing burns, and they're not, they're not doing joint replacement. They're not doing acute care when it comes to the high cost dollars. And so they're like, we're never hitting our stop loss here, and we can protect those people for those catastrophic events outside their four walls. So getting a TPA to understand was really critical, because we're like, okay, here's all the claims or all the services that happen within the four walls. And the reward of the employees is they're going to pay a lower deductible. If they decide to have care outside the four walls, then they have a higher deductible. Getting it, the PBM was essential because the hospital had its own internal pharmacy. And getting, the pharmacists of our PBM to get along with the pharmacists internally and who was right. And that was educational, because I didn't realize that some of these critical access hospitals have access to a very special GPO, group purchasing option. So no harm, no foul, because we're charging a transparent administrative fee. There isn't any spread pricing in the pharmacy. So we got through that. So
But at the same time, she's now, pushing back on us,
Yeah.
a little more
Yeah.
to, sharpen our sword, and seeing, how can we capitalize on our costs internally as much as possible. So, we're now going to have a conversation with another, potential partner that can help them, with their GPO pricing on their drugs. So see if we can find some savings there so they can actually procure the medications, through maybe another GPO at much less, cost there. And then, again, trying to steer as many of their employees to their internal pharmacy as possible.
Yeah. Yeah. And then, the other radical part of this year is to say, they said, our TPA has the ability for people for services outside their four walls to have a $0 deductible and out of pocket. And she's just pulling her hair out going, well, this doesn't make sense. If we have a surgical service here in our hospital, it's not the same one outside the four walls. Again, it's more acute care. Mm-hmm. We're charging people money for that, deductibles and out of pockets. Why can't we just do zero for, people that's, I go, great. And that's exactly what we're going to look at. And then now we don't have the liability on the stop loss, so they're going to get significant discounts. And furthermore, we're going to go ahead and revise and amend their PPO contract so that they're not going to profit from. They don't want to profit from their own health insurance plan. And I will credit the CFO. He came out of Texas, one of the nicest guys I've ever met, and he's like, here's what I think we should do. And I'm like, oh my gosh, we just haven't run into this, right? Yeah. So it's exciting to see this. And then peeling back the layers of the onion here. I'm excited about an upcoming conversation, as you just mentioned, with some folks like, we can do that. And we can do it really well. In fact, we're launching, 5 new hospitals January 1. Yep. So again, having the situational chops is key. So that one was a tough one, just because, again, you got to make these doctors in these hospital facilities, because they're the experts, and so it puts us further down the food chain of totem pole of us being the experts of healthcare, yeah. Right? So if you can make those people happy, and that's the model before I met you, that was I, but now we're a force du jour here. So we're going out, and if we can master and make the medical providers, hospitals, if we can make them happy and build them a plan like this, man, we're unstoppable. I mean, there's no bragging rights here. I'm just telling you, this is where it's at, and because now you can take that model, which is a good segue to our next discussion.
I think we're
coming around, buddy.
Here.
Yeah,
it's phase 2.
Yeah,
what's phase 2? Take it to the community.
Oh yeah.
Once we've now proven to XYZ hospital facility that, hey, this is what you're capable of. Mm-hmm. How can we now take that to the city, take that to the county, take that to other manufacturers, other employers? That can piggyback off of what they're also trying to do, and moving to an independent TPA, finding that right pharmacy partner, creating these direct pay services at the hospital facility that's right in their community that their employees are already going to.
Build a menu.
Create your own fee schedule. That, again, you've got the employer at the table, you got the healthcare providers at the table, the facilities, everybody. And then, of course, us, trying to, work as the guide to say, yes, you can do this, you can't do this, and, taking that to community, and hence, why it's called community connected health.
Right, because what's part of our DNA and the mission here, if it's not everything, and that is that we're going to figure out a way that you're going to pay less for your health care, your employees are going to pay less for their health care. So we're not just fighting this ugly battle, because inflation is never going to outpace healthcare cost inflation, and so we're just chasing our tail. And so we've seen the dismantling of our small towns, and we weren't trying to keep these young kids that we're sending off to shiny colleges never to return. Let's get some economic opportunity. And you've got people say, "Oh, it's over; it's never going to come back." I beg to differ. I think that when you get momentum on things, it's amazing how things can change.